Stop attributing the loss of steady walking to aging alone, because according to Dr. Alan Mandel, the true cause is something far more practical and often reversible, and it is rarely addressed in routine medical consultations. He explains that many of his patients in their 70s, 80s, and even 90s believed their strongest walking years were already gone, only to later discover that assumption was incorrect. Symptoms such as uneven steps, drifting toward one side, needing to hold onto walls, or feeling like the legs no longer respond with precision are commonly reported. These signs, he says, point to underlying systems that can still be retrained. A landmark finding from the Journal of the American Medical Association is referenced, showing that adults above the age of 70 who display early gait instability face an 86% higher likelihood of hospitalization due to falls within a 3-year period. In contrast, individuals who engaged in a targeted neuromuscular correction approach experienced a 71% improvement in walking stability within just 12 weeks. Not 12 years, not 12 months, 12 weeks. This suggests that balance systems, nerve pathways, and muscular coordination remain responsive, even later in life, if properly stimulated and retrained. He then breaks down the causes behind unstable walking, beginning with the 6th factor, described as a breakdown in proprioceptive communication. This refers to the body's internal feedback system that constantly informs the brain about foot position and movement. It depends on sensory receptors located in the feet, ankles, and knees working in coordination with the brain. With age, this system weakens. Research from Harvard School of Public Health indicates that sensory accuracy in the lower limbs can decline by as much as 40% after the age of 70. This creates a situation where the brain receives delayed or incomplete spatial information, forcing compensatory adjustments that result in drifting and instability. Another contributing factor involves reduced nerve signal speed, known as peripheral nerve conduction velocity. As this slows, communication between the feet and brain becomes less precise. The mechanoreceptors in the feet also begin to deteriorate, further reducing feedback quality. A study from the University of Zurich is cited, showing that seniors who spent 15 minutes daily walking on textured surfaces experienced a 34% improvement in proprioceptive function within 8 weeks. The stimulation helps reactivate sensory receptors in the feet and restore communication with the nervous system. Practical methods mentioned include walking barefoot on textured mats, grass, or uneven natural surfaces, as well as using simple household materials like folded towels. Additional activations such as ankle rotations, 30 repetitions in each direction each morning, is described as a way to prepare the sensory system before walking. The 5th factor concerns changes in the cerebellum, the brain region responsible for coordination and balance. It is reported that approximately 25% of Purkinje cells decline between ages 60 and 80. These cells play a central role in motor control, and their reduction disrupts smooth, coordinated movement. Neurological research published in the journal Neurology identifies cerebellar shrinkage as a major predictor of gait instability in older adults. However, neuroplasticity remains a key concept, meaning the brain can reorganize and adapt even later in life. A case example describes a 76-year-old woman who experienced repeated falls and a sensation of constant imbalance. After undergoing dual-task balance training, which combines physical stability exercises with cognitive challenges, her condition improved significantly within 10 weeks. The training method includes standing near support, balancing on one leg for 10 seconds, and simultaneously performing mental tasks such as backward counting in sets. Studies from Johns Hopkins University indicate that combining cognitive load with balance training can improve cerebellar-driven coordination by up to 41% over 12 weeks. Omega-3 fatty acids, particularly DHA, are also mentioned as supportive for neuronal maintenance in this region. The 4th factor involves hidden muscle loss and a condition known as anabolic resistance. After the age of 70, muscle tissue becomes less responsive to protein intake and stimulation, meaning that even adequate nutrition may not produce expected strength maintenance. Muscle cells gradually respond less effectively to rebuilding signals, leading to progressive weakness over time. A landmark study from the University of Texas Medical Branch reported that adults above the age of 70 required up to 70% more protein per meal compared to younger adults in order to trigger the same level of muscle protein synthesis. 70% more. Yet in reality, most older adults consume less protein instead of increasing it. This directly impacts walking ability. The stabilizing muscles involved in gait control, including the gluteus medius, the hip flexors, the tibialis anterior, and deep core support muscles, are among the earliest affected by sarcopenia, the age-related decline in muscle mass. When these structures weaken, walking becomes uneven. One hip may lower slightly, one foot may lag behind, and overall movement loses symmetry and stability. The correction approach requires two combined elements. The first is increasing leucine intake during meals. Leucine is an amino acid found in foods such as eggs, Greek yogurt, chicken, and certain protein supplements. It helps bypass anabolic resistance by activating the mTOR pathway responsible for muscle building. Research from MRI University indicates that approximately 3 grams of leucine per meal can restore muscle protein synthesis in older adults to levels close to those seen in younger physiology. The second element is resistance-based training focused on hip stabilizers. A simple lateral band walk performed for about 2 minutes daily, using a light resistance band positioned just above the knees, activates the gluteus medius with high efficiency. Biomechanical analysis from Stanford University suggests this movement is among the most effective for targeted activation. When leucine intake is combined with hip abductor strengthening, improvements in gait symmetry can appear within 6 to 8 weeks. The discussion then shifts to structural spinal changes. Inside the spinal cord and surrounding nerve roots transmit signals that control lower limb movement. After the age of 65, imaging data published in the European Spine Journal shows that more than 60% of individuals exhibit some degree of lumbar spinal stenosis, meaning narrowing of the spinal canal. This condition does not always present as back pain. Instead, it often manifests as neurogenic claudication, described as heaviness, weakness, or instability in the legs that worsens during walking and improves when sitting or leaning forward. It is frequently mistaken for fatigue or joint issues, but it is actually related to nerve compression affecting motor control signals. Spinal stenosis can be compared to a partially compressed hose, where signal flow continues but becomes restricted and inconsistent. This leads to sensations of unreliable or weak leg function. A case example involves Thomas, 79 years old, a retired firefighter from Nashville, Tennessee. He initially believed knee degeneration was responsible for his mobility issues. Imaging instead revealed moderate lumbar stenosis at L3 to L4. Surgery was not used. Instead, he followed a 12-week program combining lumbar flexion exercises such as pelvic tilts and knees-to-chest stretching, along with aquatic walking 3 times per week. Flexion-based positioning helps slightly open the spinal canal, reducing pressure on nerve roots. Within 2 months, Thomas reported being able to walk 18 holes of golf using a cart, but stepping out to put at each hole while maintaining full stability. A daily routine is described involving 3 minutes of gentle knees-to-chest stretching before getting out of bed, holding each position for about 20 seconds. This is intended to decompress lumbar segments and improve nerve circulation. Adding slight forward lean walking posture using a walking stick or trekking pole further supports canal opening mechanics. These 2 strategies, decompression through positioning and flexion-based movement, often produce noticeable improvement within the first week for some individuals. The next factor involves morning medication routines that may silently affect balance. Many older adults take medication shortly after waking, including alpha blockers for prostate conditions, diuretics for blood pressure control, certain antidepressants, and first-generation antihistamines. These can contribute to orthostatic hypotension, a condition where blood pressure drops sharply upon standing. Data from the American College of Cardiology shows that this condition affects up to 30% of adults over 70 and is responsible for 36% of unexplained falls in this group. The risk is heightened in the first 30 to 45 minutes after waking, when blood pressure is naturally at its lowest. Even without obvious dizziness, reduced blood flow can temporarily affect the cerebellum and vestibular system, both responsible for orientation and balance. As a result, walking may become subtly unstable after standing, even if the person initially feels fine. A corrective approach includes drinking 8 ounces of water while still seated in bed before taking medication. Research from Vanderbilt University's Autonomic Dysfunction Center suggests this may reduce orthostatic blood pressure drop by up to 50%. After medication intake, remaining seated for 5 minutes before standing is recommended. Standing should then occur in stages, first sitting at the edge of the bed for 30 seconds before fully rising. This allows baroreceptors in the vascular system to adjust cardiovascular response. Consulting a physician is also advised, as many medications list orthostatic hypotension as a side effect, and adjustments in dosage or timing can reduce risk significantly. Finally, attention turns to vestibular system failure, described as a major hidden contributor to balance loss and gait instability, often overlapping with multiple other conditions. This is presented as the central explanation for why walking becomes unstable after the age of 70, and it is described as a factor that is rarely connected to gait instability in mainstream medical evaluation, despite substantial supporting evidence. Inside each inner ear lies a highly specialized structure known as the vestibular system. It is composed of fluid-filled canals and sensory hair cells that detect head rotation, acceleration, and spatial orientation. This system functions as the body's primary navigation mechanism, even more fundamental to straight walking than vision, muscular strength, or joint function. Research published in the Archives of Otolaryngology from Johns Hopkins Hospital reports that vestibular function declines by approximately 40% between the ages of 40 and 80, with the steepest reduction occurring after the age of 70. 40%. Among adults over 75 with documented vestibular decline, the risk of chronic gait deviation, defined as persistent difficulty maintaining a straight walking path, increases by more than 300%. The vestibular system is compared to a gyroscope inside a smartphone, responsible for orientation and movement tracking. When properly calibrated, movement remains stable and coordinated. When it becomes impaired even slightly, the entire balance system is disrupted. The vestibular system acts as the body's internal gyroscope. When it fails to transmit accurate signals, the cerebellum receives conflicting sensory information. This leads to unstable vision, uneven stepping patterns, and progressive loss of directional control. Strength training or joint-focused interventions alone cannot fully resolve the issue because the root cause lies in neurological input rather than muscular output. In clinical observations, when older adults report drifting to one side, sensations of a moving floor, or difficulty walking in low-light environments, assessments often focus on joints, hips, or medications. However, vestibular function is rarely tested in primary care settings, leaving many cases of dysfunction unidentified and untreated. A case example is provided involving Dorothy, an 82-year-old retired nurse from Boca Raton, Florida. She had progressively stopped walking to her mailbox due to fear of falling in her driveway. She had consulted 3 specialists and was recommended for 2 knee surgeries, yet her vestibular function had not been evaluated. A simple, non-invasive vestibular assessment revealed significant unilateral vestibular hypofunction on her left side. The left vestibular nerve was producing weaker signals than the right, resulting in a consistent leftward drift during movement. Within 6 weeks of targeted vestibular rehabilitation, Dorothy regained the ability to walk to her mailbox. She reported standing outside in the sunlight for the first time in 2 years. The treatment protocol consists of 2 main components. The first is gaze stabilization training. The individual sits in a chair, holds the thumb at arm's length, and focuses visual attention on it. While maintaining focus, the head is slowly moved side to side, keeping the eyes fixed on the thumb. This is performed for 60 seconds, 3 times per day. This exercise retrains the vestibular ocular reflex, the mechanism that coordinates eye movement and inner ear balance signals. Research from the Vestibular Research Foundation shows that consistent training can improve vestibular ocular reflex accuracy by up to 52% over an 8-week period. The second component is habituation training, which involves controlled exposure to movement patterns that challenge balance. This includes walking forward for 10 steps while turning the head left and right with each step. The exercise is repeated for 5 minutes daily in a safe environment, often near support or with a partner. A meta-analysis from the Cochrane database reviewing 17 clinical trials found that vestibular rehabilitation significantly improved gait stability in 73% of participants over the age of 65. An additional recommendation includes vitamin D3 supplementation at 2,000 IU per day. Research from Harvard Medical School indicates that adults over 70 with vitamin D levels above 30 nanograms per milliliter demonstrate improved vestibular compensation during rehabilitation, likely due to its role in neuronal repair and calcium signaling within vestibular hair cells. Vitamin D3 is described as fat-soluble, requiring consumption with dietary fats such as avocado, olive oil, or salmon to ensure proper absorption. These findings are integrated into a broader framework explaining gait instability after 70. Contributing factors include sensory decline in the feet, cerebellar coordination loss, muscle resistance due to anabolic changes, spinal canal narrowing, and morning blood pressure instability affecting balance systems. At the center of these combined influences is vestibular dysfunction, identified as a major neurological driver of unexplained gait instability in older adults. Independence is described not only in terms of walking ability, but also in daily life functions such as shopping, family interaction, travel, and time outdoors. Each stable step represents maintained autonomy and quality of life. Clinical observations include older individuals regaining independent walking ability, previously assisted patients returning to outdoor trails, and cases of restored mobility after extended periods of impairment. The underlying message emphasizes that physiological systems retain adaptability, and that neurological and muscular responses can improve when provided with appropriate stimulation, timing, and corrective input. All reference studies, including data from JAMA, Johns Hopkins Vestibular Research, MRI University Anabolic Resistance Findings, and the Cochrane meta-analysis, are stated as available for review and discussion with medical professionals. Please leave your thoughts about this content in the comments below. Thanks for watching. See you in the next one.